All right, Ashley, I'm really excited to have you today. I have been meaning to reach out to you forever, and so I'm glad that we made it happen. I have to make sure that I say, it's funny how we think we have to justify what we look like, but obviously this is a podcast, so a lot of you are just listening to this, but a lot of people watch this on YouTube. And I'm sitting here in a toque and grubby clothes, and I live on a ski hill, and I had the choice between washing my hair and getting presentable or going for 3 runs in this beautiful bluebird day, and I chose the runs. So I have very greasy hair under this toque. So I apologize for my non-professional appearance for those of you watching, but skiing over showering. And Ashley, before we hit record, I was telling you a little bit about how I heard about you, and I just want listeners to know. So I had an SLP, a speech language pathologist client come in, and as she learned more about the pelvic floor, she said, I went to a conference this weekend and I listened to a speech pathologist and a physio talk together about the link between speech and pelvic floor. And oh my gosh, it's fascinating. And I have learned so much. And now I'm looking at all my clients with a different light. And so I stalked you a little bit, Ashley, and I was like, oh, who's this SLP? And what is she up to? And I really think that you're going to bring such an interesting perspective because somehow you've got your feet in the pelvic floor, like you've started to figure out a little bit more about the pelvic floor yourself. And so, will you tell listeners a little bit about yourself, Ashley?
Sure. So I am a speech language pathologist. I've been a speech language pathologist for over 10 years, working mainly in the medical side of things. And I've worked in various settings. So things like inpatient rehab, acute care, multidisciplinary clinics, voice clinics with ENT, and outpatient rehab. I now own my own private practice, which is a specialized private practice for voice treatment and therapy. That is my subspecialty area, although I do treat other speech and language disorders. Voice is really my passion area. I started my undergraduate degree as a music performance major and as a vocal performance dual major, with the plan of being a performer and a vocalist, and ended up with some voice issues myself, and ended up finding the field of speech language pathology as a result. And so that's why I'm so connected to the voice world. I also work, disclosure, I work as a lead mentor for the MedSLP Collective, which is a group of speech language pathologists internationally. And I am a mentor there for voice and evaluation and treatment issues. So I help other SLPs navigate that as well. And that's, I think, one of the that's the presentation I think you're referring to is a presentation I did for MedSLP Collective for one of their summits with Dr. Sarah Sohn, who is a pelvic floor physical therapist, and she's also a sex counselor, and one of my good friends. She's also a performance buddy, and we perform together. So we have a lot of similar passions. We like to talk about this stuff a lot together, and I've helped kind of make the connection through working with her.
Mm.
And it's great to be able to talk about this because it is such an interesting connection that I think gets missed in both the speech language pathology field, but also the physio field.
Totally. I that what a cool kind of similarity just there. Like just how you mentioned it was my own kind of like speech issues or singing issues that brought me to SLP. And I think that's what most pelvic health physios say is I had an issue, it brought my attention there. People need more help. And so that sounds like a similarity already. So so maybe will you elaborate a little bit more? It sounds like one of your introductions to the pelvic floor was your friend Sarah. I'm going to use the term physio and physical therapist synonymously because we just call ourselves physios in Canada. But so I'll probably say that sometimes. But it sounds like just from chatting with her, you were performing together, and then just the more you chatted, the more you kind of, oh, well, this, and then well, this, and would you say that's kind of basically just in talking back and forth with a friend?
Yeah, so I think that's part of it. Another reason that I kind of got into this part of the field and the science behind it and everything else is that I also had some voice issues additionally after I had my child, after I birthed and was having some pelvic floor dysfunction. And I was talking with other mothers who were having the same issues or similar issues. And then I started kind of watching through my case histories that were coming through my voice practice and noticing that these people all had red flags for pelvic floor dysfunction, things like urinary incontinence, pain with sex, problems with chronic constipation. And I'm like, why is this coming up like over and over and over again as a pattern? There has to be a link because I'm just
Mhm.
seeing it too frequently.
Mhm.
And so I started doing a lot of research on it and then also talking a lot with Sarah because she was a friend that I knew was in the pelvic floor field. And just trying to get a better understanding of it from the physical therapy or physio perspective, because I really didn't have a good understanding of that area prior to. And then started making the connections and was like, why are we not making this connection and why are we not talking about it? So that's kind of how I got into this area, subspecialty within a subspecialty is what I call
And
it.
don't you think that's like a huge downside to the way we look at healthcare is we compartmentalize people. Like people will often say like, "Oh, you're a pelvic floor physio." And sometimes I'm like, "Ooh, yes, but like I don't just look at your pelvic floor." And I think it's the same for you too, is you learn so much about kind of the top part of the body. You don't learn a lot about the bottom, but absolutely we're all connected. And I don't know that enough practitioners are looking at the whole body, right? And so I think that's something we're all starting to figure out is how it's all connected. And I think that's what's so exciting to me about all of this. Will you start then, Ashley, by talking a little bit about some of the things that you've learned and that you think other people should understand about kind of the similarities between what you learn and the anatomy of like the voice and the vocal cords and the larynx and the glottis and how it is similar to the pelvic floor. And I mean, I'll add a little bit as you're talking about properties of the top, I'll talk a little bit about similar properties to the bottom. So start with that a little bit about what are some of the similarities?
Yeah, so I want to start with this um, kind of anatomy and physiology discussion part by saying that within the speech language pathology literature and our coursework, we tend to look at the body from the diaphragm, the thoracic diaphragm up.
Mhm.
And as I was talking with other pelvic floor practitioners, I was finding that those practitioners had a similar experience, but kind of in reverse, where they talk from the thoracic diaphragm down to the pelvic floor and don't really go above that, whereas we don't really go below that. And that kind of speaks to what you were just saying about that holistic approach. So when we learn about voice in the speech language pathology field, we kind of look at it from a couple different subsystems of the body. The first subsystem being the respiratory system. So, the respiratory system is the power source for the voice. It's what drives the vocal folds to vibrate and create the sound that we hear when we speak or sing. And that respiratory system is reliant on the diaphragm movement and being able to get a good diaphragmatic breath. And so that's kind of where we end is the diaphragm. And when those lungs expand, the diaphragm drops down. And then once we let our air out, the diaphragm comes back up into its kind of resting dome position. And it's connected to the lungs. And that airflow is really the power source and what drives the sound. Above that, you have the airway, and at the top of the airway, you have the vocal folds, and they sit in this like nice open V position. If you look at it if you look at pictures of it, if you pull them up on Google, you'll notice that it looks almost identical to a vagina. visually. It also has very similar properties. The epithelial tissue of the vocal folds is actually identical to the epithelial tissue of the vagina when observed under a microscope. They have very similar properties as far as kind of how they work. They need to be lubricated, they want to be relaxed. And those vocal folds typically sit kind of in a nice open V position at the top of the airway so that when we breathe in and out, the air can move down into the lungs and back out without obstruction. And then once we voice, those vocal folds have to come together and then they vibrate off of one another and create the sound waves that then get shaped by our upper vocal tract to be the sound that we hear when we speak or sing or laugh or do anything with our voice. And it is a pressure system. It's the system is reliant on the pressure that's generated from the airflow in the respiratory system that then comes up and drives through the vocal folds and creates those waves and the sound waves. So that's kind of what we learn about from a speech language pathology perspective when it comes to voicing.
Yeah, it sounds so similar. Like I listen to you and think, yes, same with the pelvic floor. There's like a pressure system. You're right. We think of kind of diaphragm down. I think of same thing. I often use the analogy instead of a V or something like that. I'm thinking of a trampoline or a basket full of rubber bands, that the rubber bands have to sometimes tighten and sometimes relax. They have a resting tension, but if you need to do something harder, they need to have more tension, or the trampoline needs to tighten. But you're not really thinking about it, just like you're not thinking about your voice and trying to do something specific with your vocal cords. It's it's modulating depending on what we're doing. It's how smart the nervous system is. And I'm curious to know, because I talk a lot about the nervous system and we ask a lot about things like stress and previous trauma, and like just trying to figure out like why would someone's resting tone or the tension on those rubber bands be a little bit higher maybe. We talk a lot about it being an emotional powerhouse. And I hear, like, I am no expert on the voice, but I hear that terminology a lot, like similar emotional powerhouse tied to kind of the vocals. Like, can you talk a little bit about that? Because I can't.
Yes. Yeah, absolutely. So I love that term, the emotional powerhouse centers. That's what I use for describing the voice as well. If you think about times when you are really emotional, you can hear it in the way that your voice comes out, right? If you're really angry, your voice changes. If you're really sad, your voice changes. Those emotions just are situated there and we convey our emotions with our voice. If you think about really emotional moments in our lives, like when we're having sex or when we are birthing, those are times where people are very vocal typically, sometimes not, but it's an emotional powerhouse moment and people are using the voice as a way to experience that and move through that experience. The other piece of it that kind of goes along with the neurology aspect of it and the neuroscience behind that is that the vocal folds are connected to the vagus nerve. And the vagus nerve is one of the cranial nerves that kind of travels all over the body, but it is innervating the vocal folds. It's also innervating the breathing mechanism. And it also has some influence on our parasympathetic nervous system, which controls our fight or flight response and our stress and anxiety is tied in with that. So that can definitely be seen as like a connection to the voice and why that's the case through neuroscience.
What about then? Because I always describe to people that we're a closed system and that, the pelvic floor, maybe I use the analogy of a balloon or something like that and describe that the pelvic floor, like they come to me for pelvic floor issues. So I find that I try to start there to meet them where they're at. but describing that the pelvic floor is just the bottom, but we need to look at the front, like your abdomen. We need to look at the back. We need to look at the top, the diaphragm. But will you like that? You're right. That's kind of the um, I'm thinking about higher up, but I don't think I know how to really describe to them why it's related. Will you talk a little bit about why, in my analogy of a balloon, I'm talking about the lower balloon and you're talking
Mhm.
about the higher balloon? Like there's an almost like another balloon above the lower balloon, but
Yeah.
they influence one another, right? And so
Mhm.
it's almost like if you have a change in one, you're going to have a change in the other. So will you kind of explain that a little bit for people listening? Because, like, how does the
Sure.
top balloon influence the lower balloon?
I love that. I love using analogies when I talk to
Hmm.
patients, and it may not be 100% accurate to the science, but it helps patients kind
Hmm.
of conceptualize and wrap their minds around things. So I don't use a balloon as my example, so hopefully this might make a little bit of sense to people, but I use the analogy of a house. Our body is a house, and the pelvic floor is the foundation of the house. And then you go up, and that thoracic diaphragm might be the first floor, and then your glottis is the roof. And if I have any kind of thing going on with the foundation, then it's going to be seen higher up in the house. Or if I've got some things going on up higher in the house, it might end up then influencing the foundation. And that's the way that I tend to kind of describe it because of the connection, but it really does have to do with those pressure systems that we were talking about earlier, where there's a pressure system between that thoracic diaphragm and the vocal folds or the glottis. And that's controlled by the interthoracic pressure. And then you've got the diaphragm to the pelvic floor, and that's the interabdominal pressure system. And those two pressure systems work in concert with one another. And the way that that kind of works is that the thoracic diaphragm is the thing that connects the two. And when the thoracic diaphragm moves, it doesn't move in isolation. It moves with the pelvic floor. It cannot move without the pelvic floor. So if you've got uh, something going on, you're going to end up having some issues with the respiratory system, with the voice, further up. And that's kind of the idea behind that and how that works. I hope that makes
Yeah,
sense.
and I think, sorry, I didn't mean to cut you off there.
No, go ahead.
And I think too, sometimes again, in like at that compartmentalization of professions is, I mean, you're talking kind of thoracic diaphragm and up, I'm talking thoracic diaphragm and down. And some of the, I'm you going to say this term in quotations, like orthopedic physiotherapists feel that that's not their wheelhouse. They're thinking of kind of like the outside siding or whatever of the house. But I think about that and think about like other ways that you can increase pressure, like a rib cage that doesn't move well, muscles around that connect to the rib cage, like the muscles of the back, the muscles of the neck, the muscles of the chest, they all, if they have too much tension, that absolutely influences how much like the diaphragm can move and how the pressure, I'm sure, through the vocal codes cords translates. Because I see the same thing a bit lower down, like tension in the abdomen, tension in the back. That all absolutely influences the intra-abdominal pressure, which might be influencing the foundation as you um, said about the pelvic floor. So I think again, we all think we're not related, but it's just all looking at different things. And I think one of the take homes I think people are already getting is that, oh, my pelvic floor issue isn't just isolated. Same with my voice issue, right? I was listening to some other people talk once. I actually don't remember where it was, but they were kind of linking that the problems with the pelvic floor are similar to, like, you could describe them similar to the problems that you have with someone that you're doing voice training with, like almost like a continence issue, like that, that there's pressure coming out that you don't want to, and a lot of people see that as pee or poo, basically, that there's something coming out. Will you talk a little bit about the similarity there with the voice? Like what would kind of a
Yeah.
continence issue look like in the voice?
Yeah. So typically with that, we might see something like a vocal fold bowing or a vocal fold weakness, where instead of getting a really good seal as the vocal folds are vibrating, you get kind of this leakage of air through the sound. So you might have like a either breathy sounding voice or a weak sounding voice. Some people it sounds kind of rough or harsh. Um, on kind of the opposite end of the spectrum, we get a lot of people who have things like muscle tension dysphonia issues where they have too much tension in the system, where the muscles are squeezing too much and they can't get the sound waves or the airflow out appropriately. And that's kind of similar to your constipation issues that you see with the pelvic floor
Pain with
dysfunction.
intercourse. Yeah.
Correct. Yeah. So, and a lot of the patients that I see with muscle tension and dysphonia also have the constipation or the pain with intercourse. Like they have that tension, excessive tension throughout the whole system, not just in the isolation in the voice. Or vice versa, you know, if they've got the breathy voice, if they are leaking air, they are more likely to I'm more likely to see in their medical history that maybe they have incontinence issues or prolapse or you know something like that where they're having trouble with the continence on the other end. And so that's been my experience, my clinical experience. Unfortunately, there's not a lot of research in either the SLP field or the PT field where this like overlaps. It's very isolated. So you wouldn't see this so much in the research. There's some that's starting to come out now about it a little bit more, where we're seeing more crossover in the research. But again, we have those researchers that kind of stay in their little boxes in
Totally.
their fields and don't really look at the whole system. And I'm glad that I'm seeing more of that research out there where they are looking at it from a more holistic perspective. But
So would you say then, because as a physio, I can hear people talk. And so I notice that sometimes when people come in, I think this will open my eyes to look at things a little bit closer, but I have noticed before when people come in, like certain voices, like you said, almost like a gravelly voice, really airy voice, a very quiet voice that they can't seem to project. I have that in the back of my head and in around like, interesting. This is going to be affecting their pressure system, but I can hear that. So would you say that it's kind of something new that you've adopted then to ask people about pelvic health symptoms? And I'm sure that there's times they're like, why are you asking this? So will you talk a little bit about how you ask those in
yeah.
maybe your intake form?
Oh, yeah. So I have actually adopted asking almost all of my voice patients about pelvic floor issues, even if it's not something that is red flagged within their medical history, because of my clinical work in this area and my experience and everything else. And 95% of the time, we end up uncovering something that is kind of a red flag for pelvic floor dysfunction, which has been very interesting because it hasn't just been with a single type of voice disorder, it's been kind of across the spectrum. But what I do is I start by saying, we're going to take a holistic approach to looking at your voice problem. There's going to be lots of things I ask about that may not seem related, but could be. And I want to just kind of make sure that we're covering our bases, that we're getting a kind of full picture. And so I typically start by asking, have you had any injuries to the head, neck, or jaw? And I kind of start at the top of the body. And then I work down. Have you had any injuries to the shoulders, backs, pelvis, or hips? And I kind of lead them that way. And then I might say, are you experiencing any problems with things like constipation, diarrhea, pain with sex, or incontinence issues? And I'll talk with them about frequency urges, and I'll kind of prompt them for those things because a lot of people, if you ask them like, are you having pelvic floor dysfunction? Look at you and be like, I don't know what that means. So I do
Totally.
sometimes get a little specific with my questions. But I kind of try to prep my patient that I'm going to ask them about some really weird things. And then I'll be happy to explain why I'm asking those questions to them. And I'll usually use just a quick analogy, like the house analogy. Like, I'm asking because this is your, this is your foundation for your voice. And I just want to make sure that we're looking at the whole house and not just the roof. Um, and then if a patient is exhibiting some signs or red flags during my intake interview with them, then I usually will go ahead and give them the Cozy In pelvic floor dysfunction screening,
Mhm.
which I'm assuming you're familiar with, but I guess I
Yeah,
should
I'll
not
make sure
assume
I
if
link it in the
now.
show notes.
Yeah. Um, and so that was something that was kind of given to me by Dr. Sarah Stone, who's the PT that I've worked with pretty closely. And I have been giving that to my patients who have those red flags. And then if they score, you know, a 3 or more, I do put in a referral for them for pelvic floor physical therapy. And I do tell them why I'm doing that and explain that to them, and tell them that it's going to hopefully have some crossover with not only helping with their pelvic floor issues, but also having helping with their voice issues kind of at the same time, and finding that that multifaceted approach tends to work a little bit better.
Mhm. And then I'm sure it's not always easy to liaise with other practitioners, but I'm sure that you're able to kind of communicate with that physio a little bit to kind of make sure, because I think sometimes understandably, our clients have a hard time connecting the dots as to, okay, how is this related? And I think that's important for patients to understand why you're asking them to do something and to feel like those two disciplines are combining. Right. I think that's very important. And so I'm sure that's part of what you both do, right?
Yeah, I'm a firm believer that my patients will do better and have better outcomes if I am able to explain to them why they are doing
Mhm.
what they are doing, why I'm doing what I'm doing in therapy, and make sure that they really understand that and have that informed perspective. I find that compliance with recommendations that I make is higher when I do that. I find that it's easier for patients to kind of participate in the therapeutic experience and be more oh, what's the word I'm looking for? Engaged and
Totally.
like active in developing their goals and working towards their goals. And I find that I just have better outcomes that way. So I'm a person who's very open and honest with my patients. I like to try to tell them exactly why I'm doing what I'm doing, when I'm doing it, or before I'm doing it.
Yes.
And make sure that they really understand that before we do anything so that they know why, um, when they know the why behind what we're doing.
Totally. Make it meaningful. Actually, I think would it be helpful? I would love to do this if we talk about a few examples. I'm going to give you some examples of clients where I've been like, "Oh, this is related to their voice." And I mean, I'm obviously not going to give a lot of details, and I know that because you don't know them, you'll just be speculating on some ideas, but I think this will make it really practical for people. One is a young woman that what I would describe she was having some urethral prolapse. So she was having I could see tissue wanting to present itself around the urethra. And it was interesting because she has not had children, not really having any constipation issues or urinary issues that stood out to her. Noticing it was a little harder to go, but as we talked more and more, and I looked up around her diaphragm, how does she breathe? What's her abdominal wall feel like? Where's this pressure coming from? And it wasn't obvious to me. She didn't have some of those typical presentations that a lot of people do, but she was a singer. And
Mm.
she knew enough about her pelvic floor. She was really worried about, she said, I'm trying not to tighten my pelvic floor when I sing. But I was like, well, I think we have to play around with some things, but I think you're kind of directing more pressure down than you're projecting up. That was so I said
Mhm.
she needed to kind of play around with that. But any other thoughts on that? On some of the things that maybe you
Yeah.
would look at, or some of the things that jump out to you right away as, oh, take a look at this, consider this.
So my question would be, how did her voice sound? Did
Mhm.
it sound tight? Did it sound strained? Did it sound breathy?
I don't know that it stood out to me, but maybe I don't know what I'm looking for. That's the thing. Like it
Mm-hmm.
doesn't stand out to me.
Yeah. Um, so one of the things that I always think about with my singers is what kind of training they have had. There is there are a number of different types of training protocols out there for singers, and there's kind of different schools of that. A lot of singers are told from a pretty young age to engage the diaphragm to
Mhm.
sing, which is not actually something that we can do. We
Mhm.
don't engage the
Mhm.
diaphragm. And so, but it's a terminology that is used in that circle a lot. And so that can be really confusing for singers because then they are like trying to do something that you physically
Mhm.
cannot do,
Mhm.
and they can engage the wrong set of muscles or like not quite figure it out and create pressure in different areas where they shouldn't be creating pressure. Additionally, I've heard as opposed to engage the diaphragm. I've heard another school where people, say squeeze your tampon when you're singing. And so, like,
Mm.
people are like really over engaging the
Mhm.
pelvic floor. And so I think these terms that get like thrown around in those circles can sometimes be really confusing for people because they're like, I don't really understand why I'm doing this. I'm having trouble like figuring out how to do this because it's not explained in a way that necessarily makes sense. And I think it leads to a lot of problems with the voice, with singing, and then also with the pelvic floor because you're like trying to like figure out how to squeeze and engage and then relax all of those different muscles, and you're not getting like direct um, feedback or instruction that's explicit and in terms that are understandable. So I think that that could be something where I would ask about like, well, what kind of training have you had for singing? Tell me a little bit about the terminology that they use to explain this to you,
Mhm.
and see if you can kind of tease out what exactly they're doing when they're singing.
Yeah.
Um, my other question would be like, what type of venues are they singing in? And like, are they also playing an instrument? What's their posture? Are they doing anything repetitive while they're performing that is causing like some issues in the system? Because we often don't think about those things, but I see some singers who have problems with asymmetry because they have the guitar strap on one side and they're like in a weird position to get to the mic. And then they've got this kind of like mat, sorry, I'm losing my words here,
Okay.
but they've got this like guarding muscle
Mhm.
issue going on in the asymmetry of everything that they're just habituating to, and then they're squeezing things and then things are just dysfunctional because they've got
Mhm.
like
Mhm.
all this stuff going on. um so I might as a voice therapist delve more into those things and see if I could kind of figure out what might be um kind of underlying that,
Mhm.
um and see if I could work from there.
Mhm. Because basically, yeah, it's like a play between the pelvic floor, the abdomen, the diaphragm, the vocal cords. Like it's so many things that need to be flexible and modulating for different
Right,
pitches and
right.
projections and everything. And so it's, I think again, we go straight to like, oh, someone has a pelvic floor issue. Well, I don't know if that's the heart of it.
Hmm.
One I think a lot of people find interesting is noises in birth. So I have to tell you this. I use this lady as an example quite often. She came to see me in her third pregnancy. Um, and I said, "Why are you here? Like, what makes you think what makes you come now after the other two?" And she said, "Well, I feel like I'm getting more confident every time." But she was a very shy woman, and she said, "In my second birth, I really wanted to roar like a lion, but I didn't feel confident roaring like a lion because I don't think I knew why I was doing it, and I know that it has something to do." like it helped me. And so I want to understand why and how this is related to my pelvic floor because I felt like it helped my baby out. And I was like, oh my gosh, you're so right. But so I get people to play around a lot when we practice, what does it feel like to kind of accommodate at the pelvic floor or kind of allow
Mhm.
movement in those rubber bands of the pelvic floor,
Right.
um, ways to push and how to modulate pressure. I get them to practice with different sounds. And so will you speak a little bit to that? Because you're gonna explain this much better than I will.
So I love this question. And it's something that I think is again speaks to like knowing why you want to do what you want to do, right? But it goes back to the fact that low guttural sounds create kind of a relaxed posture in the throat and at the level of the glottis and the vocal folds. And because we have the parallel physiology of the vocal folds and the vocal mechanism and the pelvic floor, that also then relaxes the pelvic floor at the same time. So you are doing those low guttural sounds like a roar, or if you think about when you're trying to poop and you're doing that like low guttural grunt, those sounds are helpful with relaxing the pelvic floor and can create an easier exit for baby or exit for the bowel movement. And whereas higher pitch sounds are going to create more tension in the throat. They're going to, with that elongation of the vocal folds to create that higher pitch, you're going to get more tension and more resistance. And you're going to see that in the parallel physiology of the pelvic floor. And so that's kind of how I would explain that to my patients.
Mhm. And
Hopefully
I
that made sense.
No, and I think sometimes they need the feedback. So everybody's so different in how they like to learn. And so obviously I can provide feedback with a finger. Sometimes they want that where
Mhm.
I'll touch the pelvic floor, put my finger into the vaginal opening and get them to try like versus and sometimes like, oh my gosh, that I can feel the difference. For some of them they don't want me to do that. So I'll just get them, and sometimes there's a level of like embarrassment when someone's around. So say it's okay, go home and practice. Go home when there's nobody there. Maybe you put your own finger in, maybe you just feel, but you'll notice how you have to create tension in your abdomen and in your pelvic floor to make that high pitch sound, and how, in order to make that low pitch sound, you have to kind of relax those muscles. And I find that's, again, it just gives people another tool. So you don't have to use that. Maybe you don't feel like using noise, but it just gives you something else to play around with. If you want to be able to get behind why you're doing something.
Yeah.
Um, what about, will you talk a little bit about, I think we have a tendency to laugh at people. Like I think of like tennis players and stuff that grunt when they like hit the ball. And so talk a little bit about like why are why are they doing that? Like I think a lot of people are probably putting two and two together, but speak a little bit about why a noise with impact might be giving more power.
So as you create that low sound, you're creating some relaxation, which is going to help the body absorb shock and also create kind of that bounce back if you're thinking from a physics perspective.
Mm-hmm.
And so I think a lot of athletes do it because it does help with the power and creating that um, sense of relaxation. A lot of people, for whatever reason, think when we want to be more powerful and we want to um, be more athletic, we have to tighten and tense, which is actually like the opposite of what we want to do. And we see this a lot also with airway issues, with exercise-induced breathing problems, where people want to breathe faster and kind of like overbreathe when they move faster, when they are doing things like running. And it causes a lot of problems with like inappropriate vocal fold closure and breathing problems within exercise because you're creating too much tension in the system. And as a result, your athletic performance kind of tanks. And I have so many athletes that come in for just breath training
Mm-hmm.
because of that, and breath retraining, and individuals who can kind of think about being more relaxed when they're doing their sport tend to be the athletes that have higher performance.
More give in the system.
Hmm.
I also think it makes me think about all the people, like, again, I think because as pelvic health physios, we tend to cue the pelvic floor more, or people have heard that they're supposed to, but there's some people that are really quick learners, or it's trial and error. I always say it's trial and error. I'm going to give you some things to think about as you're, let's say, progressing postpartum through your exercise, or
Hmm.
maybe you've come to see me because you're leaking and you have prolapse, but you have certain exercises you're trying to get back to, and they're having a hard time with certain movements. Um, I think let's just think of, like, sometimes I think of like a wide leg position, and
Hmm.
sometimes they're confused about, so you're kind of the quote unquote like stretching those rubber bands a bit to be able to maintain that wide leg position, and maybe that is vulnerable. They feel vulnerable down in their vaginal tissues, or they feel like they're going to leak. And I think we tend to think about cueing the pelvic floor, but some people, that is not the low hanging cue for them, or the low hanging fruit, the easiest cue. I keep thinking, I wonder if I should practice like voice stuff or talking, or like
Mm.
different voices in that position to get that natural modulation or movement, instead of trying to cue the pelvic floor, because at the end of the day, I don't want them forever to be cueing over and over again, right? And it's almost like a
Right.
voice is, or changing your voice or different sounds might be an easier, more reflexive way to get better pelvic floor movement than an actual cue, right?
Right. Yeah. And I think about it from kind of the opposite side of things. Is that sometimes I can cue people for voicing stuff all day long and they're not going to get it.
Yeah.
But as soon as I'm like, hey, get in a low squat, and all of a sudden their voice clears and is like
Ah,
much more free and less effortful because they've relaxed the pelvic floor in that deep squat. Like
right.
that sometimes is helpful for me as a clinician, but I think it could work both ways. Where if, a patient is not responding to a particular cue or strategy, that it definitely could be a technique to try to kind of cue the other way. Some people are top down, some people are bottom up
Yeah.
processors, and that can definitely be helpful.
And at the end of the day, it's a reflexive pressure system. And sometimes there's certain moves. I also think too about the times where, let's say, you're like, people have glitches in their movement, or they have a certain part of the movement that's hard. We don't always know that unless they tell us, like, where in that movement are you having a hard time. But getting them, I've thought about before, like getting them to talk through a movement and see where there's a glitch in their voice or something like that, or maybe they can't talk. Like a simple movement is just sit to stand, that some people will say, like, I leak when I sit to stand. And again, I think we tend to cue the pelvic floor. Whereas I would think, I wonder if I get them to kind of talk through the movement and just be able to keep your voice up. Do you know what I mean? Like, keep your
Mhm.
voice
Keep your voice
consistent.
going.
Yeah.
Yeah.
Keep it. I don't know. I'm going to practice it a little bit more. I think
I
it's
would love
just
to
another.
know what
Yeah.
your findings are
Yeah.
after you try that a couple times.
Another thing that I really recognize, and I had almost like, I want to say, a deficiency in my abdominal wall postpartum. So I felt really like flabby in my abdominal wall. And I remember noticing this when I read to my kids. Like, I couldn't project the same, especially if I was laying down. And so I have heard before, recommendations are, especially moms, like, read to your kids, do the voices, do the big bad wolf, do the little fairy voice. Can you talk a little bit about, maybe not only as a bit of a treatment, but as a noticing? What should they notice if they're trying to, like, a lot of moms will notice, I'm having a hard time doing things with
I
reading.
I was going to say, I hear so frequently from postpartum moms that they're having difficulty with projection and with breathiness or
Hmm.
weak voice and it's particularly when they're reading to their kids or when they're trying to sing lullabies. And it's such a vulnerable time for women who are postpartum or individuals who are postpartum. I'm sorry, I should clarify that, just in any individual who's postpartum. And um, it because the voice is your identity and you're trying to connect with your child through that identity and through that voice, and then to feel like it's like not working is very emotionally vulnerable, and you're in that emotionally vulnerable place anyways. Um, and so that is something that I don't think gets talked about enough, and people don't get referrals to voice therapy for. Um, a lot of moms that I've talked to have had problems with it. They don't get referrals to voice therapy because people are not making the connections. And it's something that could be usually treated in a couple of sessions with voice therapy, you know, to kind of help out. But I do think there's a connection to the pelvic floor as well with, the the trauma of birth, even if it's not a traumatic birth. I'm using air quotes there for people that are listening. You still have some trauma to that pelvic floor, some even if it's a natural, normal birth. Um, and that foundation of the house is changing and weird and not what we're used to, and it can be really frustrating, but yeah, it can be something where playing with your voice can really help, but also doing things like, when I'm using my voice, can I be in a better posture? Can I be engaging those muscles in a more appropriate way instead of just kind of like lounging? I feel like a lot of us lounge when we read to our kids or sing lullabies, and there's, some reason for that. The kids are and the babies are maybe laying with us or kind of sprawled out on us. But it is something that is fascinating to me, and also makes me sad that there's not a recognition of, and that there's not always good access to the tools that are out there that could be potentially helpful. The other piece of it that we have to kind of recognize with postpartum voice changes is the fact that your voice is also reliant on things like estrogen, progesterone, testosterone, and hormone changes that happen postpartum can really impact the voice, the tone of the voice, how it sounds, how it functions. And that's a huge time where our hormones are just fluctuating like crazy. So that definitely has an impact as well in that time.
I think it sounds like I'm just trying to think of like kind of some take home messages, and one that just we're a complete body with lots of different systems, and to look at things, be open minded and look at things from a different angle. I can hear you've been very specific on how you have started to screen people for the pelvic floor issues, and liaise with other professionals around you to kind of look at the big person. I'm thinking for myself, not only am I going to try some of these other treatment ideas and just play around with different tools, because everybody connects to a different thing, and especially I'll ask a little bit more, like, do you like to sing in the shower? Do you like to just to try to make it a little bit more fun, and think about the pelvic floor more from like a voice connection. I also need to make sure that I'm going to reach out to some SLPs in my community and find out, because our healthcare system is different than yours. And I think everyone
Mhm.
needs to do their due diligence in their community, but just find out some people that would be interested in working in this area. And then also just find out, you know, for certain plans, do you need a doctor's referral? Like, I think that's on me to figure out what I need to do, because I have never sent someone to an SLP, but I don't think I understood when I should. Like, I
Yeah.
didn't understand that. And so now there's certain people that are like, oh my gosh, I think their pelvic floor would be helped by going there, because I might see them for a couple sessions and think, do you know what? We're not having a great change here. Let's come at this from a different angle. I can hear some changes, or I can notice some changes up a little bit higher in the house. So, what if we just come at this from a different angle? I'm going to do a better job of that for sure. And I think I challenge other people listening to just make those connections in your community and find out what you need to do in your community.
Yeah.
Um, will you, Ashley, talk a little bit about some of the things that you offer? Because just for people listening, there's a lot of people, I know you're based in the US, so things online that you do or where people can find you. I obviously will link your website and anything you want me to share, but what do you want people to know about you?
Sure. So I own a private practice in Florida called Empowered Voice Rehabilitation. We offer in-person evaluation and treatment services for individuals in the greater Jacksonville, Florida area. We also offer telepractice for anyone that's located in Florida or Vermont, because I'm also licensed in Vermont. And the way that our system works, you can't see anybody for treatment or evaluation unless you are licensed in the state that they're living in. It's kind of a weird regulation that we have to follow for our licensure. So as far as kind of evaluation and treatment, those are the areas where I can help. And I can also help refer to people in other areas that are voice specialists or have training in these areas as well. So people can feel free to reach out to me, even if they're not necessarily based in Florida or Vermont. Um, but I do offer, voice evaluation and treatment, singing voice evaluation and treatment, gender affirming voice therapy, as well as some other treatment evaluation and treatment things for other speech and language issues, which you could find on my website at www.empoweredvoicerehab.org. I also run a online course there for performers called Empowered Voice for the Performer. It's a 6-module online course that teaches performers how to better care for their voice and kind of understand their vocal mechanism from a medical perspective. I do talk about the voice pelvic floor connection during that course. So that's another area where people might be able to kind of find out more. But people can always find my contact information on my website and email me there. I'm also on Instagram at Empowered Voice Rehab. So I'm available there as well.
Awesome. Thank you so much for your time. I appreciate your knowledge and your way of explaining things and everything that you're doing to connect the professions.